Thank you, everyone, for joining for the American Psychiatric Association Lifestyle Psychiatry Caucus monthly webinar. And today we're with Dr. Anil. Neil, how do you say your last name? I didn't even ask you.
Skolnik.
Skolnik, Dr. Neil Skolnik, who's a professor of family and community medicine at the Sidney Kimmel Medicine College of Thomas Jefferson University and Associate Director of the Family Medicine Residency Program at Jefferson Health, Abington. Dr. Skolnik has written and edited 6 books and has published more than 500 articles, columns, poems, essays, and webinars in both the medical and lay literature. He hosts and produces Diabetes Core Update, the American Diabetes Association official monthly podcast that reviews the most important news articles to come out of the diabetes literature every month, as well as a Diabetes Day by Day, the ADA's podcast for people with diabetes. He's going to talk to us today about the importance of lifestyle medicine in an age of highly effective weight loss medication. And he is a very renowned speaker. I met him when we were both speaking in South Korea, was it? Is that right, Neil?
That's right, which was very cool.
It was very cool. So it's very exciting to be able to present him to our group. Thank you so much, Neil.
Thanks so much, Gia. And it really is a pleasure and a privilege to be talking to everybody. And, one would have to be like asleep for the last 5 years not to be aware of the impact of the GLP-1s and dual agonists. But I also recognize for this group, you're probably not that familiar with a lot of the details of the medicines, and you often are in the position of advising patients of yours what to do with regard to whether or not to use a GLP-1 or how important are the different lifestyle things that used to be central to weight loss now that we have medicines that can allow one to on the average, for instance, with tirzepatide, to lose over 50 pounds over 72 weeks of the trial. So what I've done in thinking about how to best serve your needs is I'm going to go over a bit about just the landscape of obesity. I'm going to spend some time talking about the treatment so that you're familiar with the different medicines that your patients are on. And then I'm going to try to answer that question, the core piece here, which is where does diet and exercise fit in now that you're going to lose weight, whether or not you actively pay attention to diet and exercise. So it really raises some interesting questions that are really of critical importance. The way I want to address questions, I think questions are best answered in proximity to when you have them, not saving them to the end and having no time left. So there'll be some logical breaks, and I'll ask Gia if there are any questions. Feel free to submit the questions through the chat function, or Gia, if you prefer, since there's not a ton of people on here, people can just ask them verbally. It's my pleasure. Here are my disclosures. I am on advisory boards for every company that makes weight loss medicines. I do speak for some pharma companies in the area of diabetes and my other area of interest, which is respiratory asthma and COPD. Our learning objectives are essentially what I talked about. And I like just starting with a picture of 3 infants. And if you think about whether you know anyone who's had a child in the last 5 years, it's sobering to think that 1 out of 3 kids born in the last 5 years will at some point in their life have diabetes, and 2 out of 3 of them will have either overweight or obesity. So there is a enormous epidemic related to weight, and we'll talk about why that a little bit, that we need to address. And we need to address that truthfully at a primary prevention level as well as a treatment level. And we see that the rate of obesity has gone up over fourfold over the last 50 years. And currently the rate of obesity among United States adults is over 42%, with a full third of adults also being overweight on top of that. The rate of diabetes has increased enormously also over the last 40 to 50 years. Now 1 out of 6 adults have diabetes. And the consequences of overweight and obesity are large. They're metabolic. Obesity leads to fatty liver disease, fibrosis, diabetes, cardiovascular disease, but also biomechanical. People forget that. You put excess weight, you're going to have knee pain, hip pain, back pain. And also, as well or better than I do, the issues around the psychological effects of adverse body image. The other thing is, if we just stand back and look at mortality, beginning at a BMI of just over 22, and remember, 25 is top normal BMI, 25 to 30 is overweight, 30 and above for BMI is obesity. Above 35 is class 2 obesity. Beginning at a BMI of 22, above that you begin to see this increase when followed over time in mortality, such that when you get to a BMI of 30, for adult men, you have about a 20% increase in mortality. By a BMI of 32, your mortality over 20 years is increased by almost 50%. So the effects are large, and there are two competing theories as to why there has been this increase in obesity and diabetes over the last 50 years. And they're called the energy balance model. And that's the one we've all been taught. You have more calories in than calories expended, and you gain weight. But many people feel that that is simply repeating the law of thermodynamics. It would be like saying, why does a child have fever? They create more heat than they dissipate. They have fever, but not adequately explaining what's going on. The other is the carbohydrate insulin model, which says that it is the types of food that we've been eating, particularly highly processed carbs. When you eat a highly processed carbs, your glucose goes up very quickly, with that followed by a spike in insulin. Insulin changes glucose to free fatty acids when it's not used for energy, and it gets stored in adipose tissue and in the liver. And then glucose suddenly from that high spike in insulin drops. You feel voraciously hungry, and it's that voracious hunger that drives you to continue eating more and more. Regardless of which model you are a proponent of, and the truth is that it's both, in my opinion, what everyone agrees is that core issue is this toxic food environment, the ready availability of inexpensive, highly palatable food that has been marketed to us and our kids in a way that makes it hard to resist, such that we eat in excess and we override our body signals of satiety. Why this is important is that once you have gained the weight, your satiety signals get distorted. Your hypothalamus, which is the site of the satiety center and appetite center, begins to be less responsive to the satiety signaling, things like leptin, GLP-1s. It becomes resistant to that. And when you lose weight, two things happen. One, you decrease the amount of satiety signaling. Leptin and GLP-1s are an example, and your brain is very sensitive to drops in that signaling, so you become very hungry. But the other thing that happens is, even if you can override that, even if you can not eat, your basal metabolic rate, and this has been shown in multiple articles since the late 90s, and there's a wonderful article in New England Journal showing this. Your basal metabolic rate after about 3 6 months of a calorie deficit drops. So that 300 calorie deficit each day that got you to lose, a couple of pounds a month, pound to two a month, at the end of 3 to 6 months, you stay on that deficit, even if you can, your weight loss levels out and you begin to gain weight on that calorie deficit due to a decrease in basal metabolic rate. And I say that so that people really understand this concept of obesity as a chronic disease. It is not a failure of will. I will say that again. It is not a failure of will. It is a byproduct, once one has gained weight, of all these hormonal shifts. Before I go on to talk about interventions, any question to this point in terms of that concept of, particularly of obesity as a chronic disease? Okay, let me continue on. So there are three primary interventions: lifestyle, pharmacologic, and bariatric surgery. When we look at lifestyle, that is the best programs out there where you're meeting with a dietitian, personal trainers, weekly and then monthly for a year. You achieve about 5 to 8% weight loss by the end of the year, but most people regain significant weight. Important to realize that's not everyone, most people. In general, if you want to lose weight, you have to calorie restrict. You can't exercise your way to weight loss. It takes excessive amounts of exercise. So diet is important for losing weight, but it's almost impossible to maintain weight loss by diet alone. Exercise is important for weight loss maintenance because of what I talked about, that decrease in basal metabolic rate that occurs if you're not exercising to push up that calorie burn. When we talk about exercise for weight loss maintenance, we are not talking about that 150 minutes a week that we're all familiar with, that's recommended for most people. To maintain weight loss, you need about 250 to 300 minutes a week of exercise. And obviously that is hard for most people to sustain.
So real quick, Neil, you're talking about 250, 300 of moderate or vigorous?
That's moderate
Moderate.
intensity exercise. Very good point. If you can sustain vigorous exercise, it would be about half that. I emphasize moderate intensity because when we're talking about people 40 or 50 and older, most vigorous activity is mostly a byproduct of imagination. When we stand back and look at the amount of weight loss that we achieve with different approaches, we talked about lifestyle. The first generation medicines, naltrexone, bupropion, liraglutide, phentermine, topiramate, get you in that 6 to 9 or 10% weight loss range. Bariatric surgery gets you 25 to little over 30% weight loss. But our second generation weight loss medicines, and since this is a CME talk, I can only talk about brand names once during the talk, is the rules around CME. So semaglutide is Ozempic when used for diabetes, Wegovy when used for weight loss, tirzepatide is Mounjaro when branded for diabetes, and Zepbound when branded for weight loss. When we talk about semaglutide and tirzepatide, we're talking about 15 to 21% weight loss, and we're going to take a deeper dive on those two in a few minutes. So let's now go on to pharmacologic weight management. And we talked about, what we see with the different medicines very briefly, because your patients may be on these. Phentermine is an amphetamine. It is not FDA approved for chronic weight management. It has only been studied in small trials for 3 months. A couple of trials that go 6 months, not a FDA approved, though until recently the most commonly used medicine, and it works okay, around 5% weight loss. It's an amphetamine. You don't want to use in people who have coronary disease. Doesn't seem to have the same addictive qualities as other amphetamines, and that's not based on the literature, that's based on most people's anecdotal experience. I try not to use this much anymore. The advantage of it is that it's inexpensive. The two first generation medicines that occasionally we'll use because they're a lot less expensive, about with a coupon, they're about $100 a month, or bupropion, naltrexone, and phentermine topiramate. Bupropion, naltrexone is fascinating, right? There's this addictive quality to food, the hedonistic quality that overlaps in terms of receptor sites with the opioid receptor. And that's where the naltrexone fits in. Again, weight loss on these two medicines, 6 to 9 or 10%. They're tolerated pretty well. I don't love phentermine topiramate because it's phentermine on the one hand, and topiramate can make people a little bit fuzzy cognitively. Not everyone, it's a low dose here. But we use them occasionally still, primarily because they're less expensive if someone's insurance doesn't approve these second generation medicines. And then orlistat, which is not used, I don't use it at all. It's not used very much in the United States because primarily it causes GI upset and particularly a lot of gas or oily stools, which isn't attractive. When we think about our modern medicines, and what's so amazing, right, about what we all do is the rate of change here. I can't believe that when I'm talking about modern medicines, I'm restricting my discussion to like the last 5 years, right? Not even. But the world has changed a lot with regard to obesity management just in the last few years. So these are all incretin-based weight loss medicines. The first one was liraglutide. I'll mention the brand name here once. That's Victoza when used for diabetes and Saxenda when used for obesity. The thing about liraglutide, the reason we don't use it very much anymore, as you can see, weight loss not great, 8%, and it's a daily injection. But wow, semaglutide and tirzepatide, fantastically effective. Main side effects are GI, some nausea, occasionally vomiting, diarrhea, or constipation. Either can happen. We'll talk in a little while about how to help people through that part. And occasionally people can have hair loss. The disadvantage, these are very expensive. They're over $1,000 a month and a range of coverage depending on one's insurance plan. I want to take a little deeper dive into each of these because these are the ones that your patients are on and we're most interested in, and they're most exciting. So the step 1 trial of semaglutide, and you see the curve here for weight loss. This is amazing. We never thought we'd see anything like this. 15% weight loss on the average, or 16.5% weight loss on the average over the 68 weeks of the trial. You see the breakdown in terms of the amount of weight loss, the number of people who get over 5, 10, 15, and 20%. All you can say is, wow, this changed the landscape. What becomes fascinating here, the step 3 trial, semaglutide once weekly versus semaglutide with a lifestyle modification, right? So we're talking about that today. So the active arm got an intensive program, really well developed, a lot of classes with dietitians, personal trainers, a lot of support, along with semaglutide versus intensive behavioral therapy, versus semaglutide alone. And, there was not versus intensive lifestyle alone. The title here is wrong. So basically 16% weight loss with semaglutide versus 5.7% for intensive lifestyle alone. What's fascinating here, if we compare this to what we got in the step 1 trial with semaglutide, that was 16% weight loss here, intensive lifestyle modification, and semaglutide virtually the same. It's not a head-to-head trial. Everyone was disappointed. I think we all thought that we were going to see better results when you add intensive lifestyle modification, exercise and diet to active drug. That was not the case. We'll come back to that.
Can we ask a question really quickly?
Yeah, please.
So when you go back to the side effects, that were they significantly reduced with microdosing?
Good question. Microdosing is not done in the trial, so there's no clinical trial data on microdosing. the doses in the pharma manufactured doses, you can't microdose essentially with semaglutide. It comes in a pen device. Um, I know that microdosing is being done out there. The reason that for all of these medicines, you start at a low dose and you have a minimum of 4 weeks in between titrations is that the body accommodates to the medicine. And if you go up too quickly, you get tons of side effects. So one would expect if you started at a lower dose, you would have less side effects. I do have concerns, and I can come back to the issue of compounded medicines later if you want. Yeah.
So there's a follow-up. Achina, do you want to just unmute yourself and ask a follow-up question?
Yeah, what was the follow-up question?
You said the
Yeah,
cut.
oh yeah, well, you asked if there are side effects with are they reduced with the microdosing? So what about like if you did do the diet, you're saying that the diet didn't change results with whether it was with or without, or the semaglutide didn't change results whether it was with or without the lifestyle
Right.
changes. If they had them with the lifestyle changes and then the semaglutide was discontinued, did they sustain those results? Because I find that a lot of people are on the semaglutide without the lifestyle changes actually end up gaining all that weight back when they stop the semaglutide.
That's exactly where, so you anticipate where I'm going with this talk. And I'm going to say we'll come back to that question because I'm purposely am addressing that in the second half of this talk. And that's one of the reasons that we
Awesome.
want to do exercise and diet is in order to be able to sustain the weight loss when we come off of the medicines. And you so correctly anticipated where the importance is. It's not in getting better weight loss when you're on it. So I'm going to move on here because there's another point I want to. Tirzepatide, we see even more weight loss. So 22% weight loss. And to put this into pounds, the average weight on entry to the tirzepatide trial was 235 pounds. There was an average of 52 pounds of weight loss. Again, we never thought we would see anything like this.
Wow.
Now here, I mean, that blows you away, right? Now here in the SURMOUNT-3 trial, they did this lifestyle intervention a little bit differently. They front loaded with lifestyle, diet and exercise for 12 weeks. Only the individuals who lost more than 5% of their weight on intensive lifestyle modification were allowed into the randomized part. Here, what we see, if we front load lifestyle, we see a little better weight loss, 24% than we got with tirzepatide alone, but still not as impressively better. And the point here is when someone's on these medicines, the heavy lifting, if you will, is being done by the medicines. And you so correctly anticipate because if you make big efforts, you want them to be meaningful. You won't see the meaning of them while you're completely while you're on the medicine. There are some effects, and I'm going to come back to that too in a minute. But I don't want there to be confusion about what we're trying to achieve. And you get about the same results with or without lifestyle with regard to weight loss. But we're going to come back to this issue because weight loss isn't the only metric. I want to move on now to body composition. And this is from an article. These were MRIs of a 40-year-old triathlete, an older guy who's sedentary, and an older guy who is still an athlete. And white is fat here. The brown is muscle. You don't have to lose muscle with age. Most people do. Why is that important for our discussion? Because no matter what you do for weight loss, your body doesn't only take it from fat, it takes it from muscle too. If we look at in the two large obesity trials, the tirzepatide trials, SURMOUNT-1, step one for semaglutide, they did a subset of people who got DEXA scans, which is the accurate way of looking at body compartments. Whether you look at, and you see it here, the tirzepatide or the placebo group, you have, when you lose weight, about the same proportion of lean body and fat body mass lost. Obviously, if you lose more weight, you lose more of both. And what we find that is that in the semaglutide and the tirzepatide studies, you have about a 10% decrease in lean body mass. That's muscle. Now, is that important? I think it is. I don't want to go into a deep dive on the debate about what type of muscle is lost, how important it is. To me, this is clearly important, and it's really important for our people who are over 60, right? With age, you get this normal waning of muscle, obesity, rather age-related sarcopenia. Someone over 60, you got to do all you can to help maintain muscle mass. And we're going to come back to talk about that as one of the critical things for lifestyle intervention. I don't want to lose the fact that these medicines are incredibly cardiometabolically positive. They decrease blood pressure, they decrease blood sugar, they decrease LDL cholesterol, raise HDL cholesterol, decrease triglycerides, unequivocally beneficial. And there's more and more trials coming out showing effects, positive effects on specific areas, like the SELECT trial, which showed in people with overweight and obesity a decrease of 20% in recurrent MI and stroke in people who had had such already over 3 years. STEP-HFpEF is a heart failure trial. There's now a tirzepatide heart failure trial, both incredibly positive. And tirzepatide was just this past month approved for treatment without CPAP, approved for treatment of obstructive sleep apnea because it resolved obstructive sleep apnea in half of the people with obesity and sleep apnea, moderate to severe, enrolled in the trial. There's another study coming out on tirzepatide looking at cardiovascular outcomes, and there are trials out on MASH, formerly called NASH, showing decreased reversal of fibrosis with both semaglutide and tirzepatide and improvement in arthritis, pain, and function. These are incredibly beneficial medicines in many different aspects. So now, for the second half of our discussion, we're going to focus on the question that really is the main agenda here, which is if the meds are so great and they're metabolically beneficial, why make the effort? Where's diet and exercise fit in? But before we go on to that, let me answer any questions like up to this point.
Yes. Kamlika, do you want to unmute yourself and ask the question?
Yeah, I was just wondering if the GI side effect of tirzepatide eases out over time when somebody continues the same dose.
Yeah, great question. And it does. And again, there's no answer that fits every single individual, but I would say for most people, what you see is the main amount of side effect is that first month. And we really work hard to get people through that first month sometimes. About 2/3 of people actually tolerate it really well, don't have side effects, but the third who do are not happy because, right, like stomach ookiness, for want of a better word, is not a comfortable sensation to be walking around with all day. And you just got to warn people about it ahead of time and, help them, small meals. And I think I have a slide on this a little later, but, don't eat that one big meal.
Yeah.
Once a day. It's small meals, break up meals. I think we talk about that a little later.
So one more question, Sylvia, do you want to unmute yourself and ask your question, please?
Yeah, sorry. I was wondering about the hair loss. Is that reversible? Is it getting better, or do you need to stop the medication?
Yeah, it probably is reversible. We don't have clinical trial data there, but I can say anecdotally, what happens with any weight loss, right? You have these different stages of hair growth. And when you're sick, for instance, you lose a lot of hair, but it's not permanent. It comes back. Now, when we talk about people who are older, I think things change a little bit because whether it's loss of muscle or loss of hair, there's not always the same resiliency and bounce back in older individuals. But for most people, I think that starts regrowing a few months later. But if you don't warn people about it ahead of time, people are not happy, and they shouldn't be. Any other questions before we move on?
There was just one comment. Achina said that that she actually had someone's autoimmune AB drop dramatically as well.
Autoimmune what?
Antibodies. I'm assuming.
Yeah, I've
That-
had patients who've been on tirzepatide specifically have a drop in antibodies like Hashimoto's,
Oh, that's interesting.
lupus. Yeah.
Interesting.
Pretty
Yeah, all I
dramatically.
would say there is interesting. I think we're learning a lot of, I don't know data on it, but we are certainly learning a lot about these medicines as we go. As you know, there's also early data on, helping with addictive behaviors, both opioid addiction and alcohol addiction. So there's just an immense amount of study going on. Let's continue on now, and we'll come back for more questions. So, if we think about the importance of lifestyle while on anti-obesity medicines, I think of it in terms of four main areas. One is mitigating the side effects, which we were just talking about. One is optimizing body composition, critically important as we get older, particularly. Another is optimal long-term health, because we don't only care about weight loss, we care about health. And then something that, what a great question you anticipated. How does what we do while we're on the medicine affect our ability to maintain weight loss when we come off the medicine? So I'm going to present you data because we like evidence, but I'm happy to also share opinion. So one, dietary advice to mitigate the side effects. And your question alluded to this. So one, avoiding fatty, greasy, high sugary foods. Well, how great. Try and use the opportunity of GLP-1s to move from a less healthy to a more healthy diet. That's an important theme of what we can do. Eat slowly. I know that seems obvious, don't stop eating when you're full. It may be obvious, but all of us experience, particularly when we're hungry. We eat too quickly and we don't stop when we're full. I earlier tonight didn't stop when I'm feeling a little bit of that, and we all do that. But so we want to be mindful about our eating. Eating smaller, more frequent meals, GLP-1 slow gastric emptying. If you eat a big meal, it's coming back up. You want to avoid that. And to make sure to stay hydrated, because when we interfere with the appetite mechanism, we also, for some people, interfere with the thirst mechanism. And there have been reported cases of acute renal failure due to dehydration on these medicines. Next. Optimizing body composition. This is critically important. We talked about the loss of muscle mass. There are two ways to mitigate that. One, adequate protein intake. There's no exact numbers here. 0.8 to 1 to 1.5 grams per kilo per day. Half that much is per pound per day. And physical activity, but here, not what we often think about, which is aerobic, which is running, but also resistance training. That would be light weights or bands. And for patients who have the resources, I ask them to at least go to a few sessions with a personal trainer. This has become such an issue in our office, and one of our residents is actually a nationally rated weightlifter. He stepped forward and started a exercise clinic for our patients so they can learn how to do resistance training with him. There's lots of YouTube videos, lots of ways to learn this. Let's now move on to diet. So a couple of pieces of evidence and then some thoughts. So the Mediterranean diet, we know there's good data to show that it is healthy. This trial looked at up to 21 years of follow-up. And what's fascinating here, they broke this down by weight category. And what you see here in every weight, normal, overweight, and obese, right? That the green representing the greatest adherence to the Mediterranean diet. And the endpoint here is all-cause mortality. No matter the weight, within that weight category, When you eat better, you do better. And that's critically important because weight is not the only metric. It's the metric many people focus on. It's the metric that, unfortunately, when someone goes online and gets their cheap compounded medicines, they're looking at weight. In our offices, we ought to think about health, and that's using the opportunity that the GLP-1s give us to move toward to develop healthy habits. I'll share some thoughts there too in a minute. Whole grain intake. Meta-analysis of 20 trials. This did not break people down by obesity, so this is all comers. But if you're eating 3 servings of whole grains a day, 17% lower risk of all-cause mortality. This other trial, meta-analysis of studies, broke it down by more granularity, by food groups, and we're seeing this decrease of anywhere from a few percent up to 24% when you eat healthy foods. But you put it all together, because none of those individually look very impressive. But optimal consumption of risk decreasing foods resulted in a 56% reduction of all-cause mortality, age adjusted. That is a big deal, which is why when it comes to diet, I talk a lot about, you just see what our next, I talk a lot about the GLP-1s in essence give us an opportunity. They take away the need to concentrate on eating less. It's hard when you diet, and you got all this food noise, and it's like, I feel like eating, I feel like eating, I feel like eating, can't eat, can't eat, can't eat. You're so consumed with it. The GLP-1s help get rid of that food noise. And I like the term the small ask. What we're asking now isn't to fight every instinctual urge that evolution has put into our body to get more food. But let's now focus on 2 things. Let's focus on eating a healthy diet, moving from perhaps Doritos and Twinkies to vegetables and lean protein, and exercise. And I want to go over the data on exercise now. When we look at exercise, this is from an article from 3 years ago, British Journal of Sports Medicine. This was a meta-analysis of 196 articles, over 30 million participants, right? A lot of rigor to this data. Look at the relationship here between METs, which none of us have a clue what that means. So I put in arrows here for where 150 minutes a week fits in. It's about 7.5 METs. At 150 minutes a week, all-cause age-adjusted mortality decreases by about 25 to 30%. That's a big deal when people are exercising the recommended, U.S. Department of Health recommended amount of exercise. But what's even more interesting, and I think encouraging, at 75 minutes a week, we see about 3/4 of the effect we get at 150 minutes a week. This study changed the way I approached the discussion of exercise. And what I mean by that is people all the time when I talk about exercise say, but I don't have time. And I, reasonably empathic guy, I'm like, yeah, I know it's tough. 75 minutes a week, 10 minutes a day. I say, I don't believe you. You have the time. 10 minutes a day to decrease the likelihood that you will die over the next 20 years by 25%. You have 10 minutes a day. Let's figure out where that's coming from. It may be TV, it might be sitting in the bathroom, I don't know where, but I know you can find 10 minutes. And we work first on developing the habit, later on increasing intensity of exercise and duration. We see the same sort of curve for cardiovascular mortality, and less well appreciated, the relationship between exercise and cancer. Actually, if we look at breast cancer in women, women who exercise have a 45% lower incidence of developing breast cancer than those who don't. It is primary prevention at its best. Colon cancer, about a 30% decrease. This is primary prevention at its best. The authors of this trial estimated that 1 in 10 premature deaths could have been prevented if everyone achieved even half that recommended level of physical activity, that 10 minutes a day. Let's go on now and look at exercise mitigating the risk of obesity. Here we see a breakdown by obesity class. 7.5, the blue line is 150 minutes or more of exercise a week. And what becomes fascinating when you look at this breakdown, if we look at someone who's normal weight and we compare that to someone who's class 2 obesity, that's a BMI greater than 35, if you exercise and you have class 2 obesity, your years of life lost is the same as if you don't exercise and your normal weight. The same is true in diabetes. Exercise mitigates the risk incurred by other risk factors. And of course, within any category, if you exercise more, your risk of mortality goes down. I want to make sure we have enough time for discussion, so I'm going to move through the next couple of slides pretty quickly. Basically, this trial looked at unfit versus fit in a very large cohort, and what we see is what we expect. Those who are less fit have a higher risk of all-cause mortality, such that if we look at under any category of BMI, normal, overweight, or obese, in those who are unfit compared to those who are fit, we see this increase in the risk of all-cause age-adjusted mortality. And if you look at people who are obese, that's a 65% increased risk. That's a lot. And in this large cohort study, they looked at the relationship between fitness, BMI, and mortality over 20 years. And I just like this, not because it says something different, but because there's a nice graph. And you just see that if you are not exercising, that's that sad orange line here. If you're not exercising, your BMI is high. You do not do well. People who are middle-aged at entry to the trial. But if you are able to exercise, you begin to mitigate that risk. And that's that green line up top. So exercise has incredible benefits. We see the same with diabetes. Does exercise offset the increased risk of diabetes? The answer here is yes. If you're inactive with diabetes, that first line, the relative risk for mortality compared to those who are inactive without diabetes is almost threefold. If you are active with diabetes, that third column, look at that. You bring your risk back down to what it was if you were inactive and didn't have diabetes in the first place. Exercise is the great fixer, the great mitigator for other risk factors. What are the recommendations? Aerobic activity, 150 to 300 minutes a week. But if someone can't, 75 minutes, 10 minutes a day works, does huge benefits. I want to remind you, though, if we're talking about weight loss maintenance, not cardiovascular outcomes or cancer outcomes, we need higher amounts of exercise, 200, 250 to 300 minutes a week. And in the context of weight loss medicines, resistance training, critically important to maintain muscle mass. I'm not going to spend a lot of time on sleep and stress. You're probably more familiar with this area than I am. Just want to mention it's part of the package, right? Want to encourage good sleeping habits. Stress, the relationship between stress and cardiovascular outcomes has been known for, at least 40 years or more, since George Engel, a psychiatrist at University of Rochester, coined the term the biopsychosocial model of medicine. Heightened stress can lead to a twofold increased MI risk after adjustment for other cardiovascular risk factors. So, in conclusion, then we'll open up for discussion for the last 10 minutes. When we talk about health, we're not just talking about weight. The GLP-1s help us achieve weight loss like nothing we could ever have imagined. And it does it while also helping us achieve improvement in cardiometabolic outcomes and decreasing recurrent MI in people who have had it, and decreasing fibrosis in those who have fibrosis from fatty liver disease. But it's not all about weight. We want to make sure we are also paying attention. Now, I want to come back to the question that was asked. How long do I need to remain on anti-obesity pharmacotherapy? There's some clinical trial data here that I think can be deceiving. There are two trials, STEP 4, SURMOUNT 4, basically run-in for both these trials, semaglutide and tirzepatide, was active drug titrated to target dose, but then they stopped at cold turkey. And you see these in both trials, people gain weight very quickly, regain the weight. That's what you talked about. I don't think in real life we'd ever cold turkey stop these medicines. We shouldn't. We should wean them down. And we ought to have really emphasize and plan for when we're coming off of the medicines. Even at the end of the trial, people did maintain significant amounts of weight loss. But when we look at real world data, and this is from a large Kaiser cohort, about half of the people who came off of GLP-1s a year later maintained at least a significant amount of their weight loss. There's only one trial that informs us as to what exercise does. In this trial, they randomized people to usual activity plus placebo, basically nothing done. Exercise alone, usual activity plus liraglutide, or intensive exercise training plus liraglutide. And what we see here, the bottom red is exercise and liraglutide. The light blue is liraglutide. People had a run-in period, 52 weeks on the medicine. And this dotted line is when the active trial was stopped, but people were still followed. And here's exactly what you were saying. The people who exercised and got liraglutide, even after liraglutide was stopped, that's the red line here. They maintained significantly more weight loss at 52 weeks after all the drugs were stopped than the group that got liraglutide alone, that gained weight to the same, or actually numerically a little more, than the placebo group. So what do we do with that information? And this basically says the same thing. So what do we do with that information? I think this means that when we start on this weight loss journey, we have to also start with lifestyle. And we have to talk to our patients about health, and we have to talk to them about the off ramp and how what we do as we're on the medicines will help us if we're able to come off the medicines. My personal opinion, there's no evidence. This is not coming from evidence. This is opinion. My personal opinion is that we'll see 20 to 30% of people who will be able to slowly wean off the medicines and maintain an important amount of weight loss. And those are going to be people who, through a combination of genetic resetting, that some people just will, and the habits they acquire, right? And habits are not easy to develop, but once you develop them, you can keep them. You know, move into healthy eating, vegetables, clean eating, lean protein, and then at least 200 to 250 minutes of exercise a week. And I can tell you it's doable. It isn't easy. I promise you it is doable. And I promise you it's not easy, and it has to be maintained long term. But I think that it'll allow us to see some people come off the medicines, but not the majority of people. So when people ask, how long am I going to need to be on the medicine? My answer is always as long as needed. I'll be there with you. We're going to help you maximize the chances of coming off. It may be long term, it might not. We don't know. And that's basically summarizes where I see the state of the art right now. We also, of course, want to talk about sleep, stress, social engagement, all of the usuals. And I like thinking of the term the small ask. When we are no longer asking our patients, I alluded to this earlier, to every day, every minute, fight their instinctual urges to eat. The GLP-1s take care of that by dampening appetite. We still need to ask something, and that's to learn that healthier diet and to learn and incorporate the habit of exercise. So if we do that, we meet our goals. You know, we talked about mitigating side effects, optimizing body composition, etc., and optimal health. And there's one quote that I always like ending on, and that's by someone named Les Brown, and because it is not easy doing lifestyle modification. And and this person put it really nicely. He said, if you do what is easy, then life is hard. But if you do what is hard, then life is easy. Let me open up the floor for the remaining 7 minutes to any questions.